Thank you so much, Dr. Chu. Hello everyone. So my name is Sean. I am really honored to be able to discuss my project with everyone here today. So without further ado, the title of my project is Evaluating the Efficacy of Lemborexant in World Trade Center Exposed Cohorts with Comorbid PTSD and Insomnia. And this is actually something that's really important to me because it was something that I started back in my pulmonary critical care fellowship. So it's something that I've been now doing for about over a year and a half, almost 2 years. And so let's discuss a little bit about how this had come to be. So why did we choose this topic and why did we choose this population? So my interest predominantly is in sleep medicine. I'm an outpatient sleep medicine physician that also does some inpatient pulmonary critical care work. But when it comes to insomnia, so this is something that is highly prevalent. About 10% of adults in the general population carry a diagnosis of insomnia. And I'm sure as many medical professionals are in this room, oops, sorry, up to a third of adults, if they don't carry a diagnosis of insomnia, at least experience one nocturnal symptom that's related to insomnia. And this can really be either sleep-related complaints, so they can have issues with initiating sleep, which is sleep latency that is over 30 minutes, or they can have difficulty with maintaining sleep. And that is not just nocturnal awakenings in the middle of the night, but that's also difficulty returning back to sleep. And furthermore, you can have daytime effects of insomnia. So you could complain of when you wake up that you felt like your sleep was non-restorative, that your sleep was poor during the night. And unsurprisingly, many people complain with issues with cognitive function and energy subsequently during the day. And we see that it's not just subjective measures. So we see that on polysomnography that there are these signals for patients with comorbid insomnia or primary diagnosis of insomnia. And what we see is the prolonged sleep latency. Patients spend an increased amount of time awake after there's initial epoch of sleep. There's unsurprisingly a reduction in total sleep time. But you can also see that their sympathetic responses are elevated. You'll see increases in their arousal burdens, and you can also see decreases in stage 3 sleep, which tends to be our marker of homeostasis and where we really consolidate memory and allow for hormone regulation. And we see that their EEG, their cortical EEG, is a little bit more active objectively on these measures as well. And what we see is in the 9/11 cohort, so unfortunately, there's a high prevalence of various diseases in this population. A lot of times we'll see them from a respiratory standpoint due to their inhalational exposure, but you can also get gastrointestinal complaints, patients with significant rhinosinusitis, they see ENT. And again, so there's a high prevalence of psychiatric comorbidities in these patients. So things like depression, anxiety, and PTSD is often seen in this cohort. And when it comes to PTSD, that's one of the psychiatric comorbidities that tends to have a higher correlation with sleep disturbance. And again, as we talked about, can lead to impacts in daytime function and mood. And so this bi-directional relationship is really important. If you have poor sleep, it's going to affect your daytime mood, and if you have issues with your daytime mood, it's going to affect your sleep. And that is something that's been documented in multiple different studies. But the interesting part in how we got to the study is that part of this neural circuitry and this retrieval of the fear response that we can see is actually thought to be modulated by these orexin-specific neurons. And why this is so pertinent to sleep is because orexin is something that has widespread effects across the brain. So when we talk about orexin, it's also known as hypocretin. It's they tend to localize in the lateral hypothalamus, and they can have wide projections. So you can see that this is the ascending arousal system in the brain, and you can see that the lateral hypothalamus orexin neurons, they can go to the tubomammillary nucleus that affects histamine. You could have them in the ventral tegmental area that affects dopamine. They can affect the dorsal raphe with serotonin. You can have them in the pontine regions, which affects acetylcholine, and the locus coeruleus, which affects norepinephrine. So you can see how tightly interlinked these excitatory neurons are with orexin. And so you could just, infer from this widespread effects that the sleep regulation and the fear response in PTSD are pretty closely related. So what was our hypothesis? So we thought that patients that would be treated with the FDA-approved orexin antagonist, lemborexant, would actually experience improvement in both their PTSD and insomnia complaints. And we were looking at both subjective and objective markers. So how did we do this? So we proposed a single center prospective randomized double-blind controlled trial that actually was a crossover design so that the patients who were treated would serve as their own control. And we estimated about a sample size of 25 in order to determine statistical significance. And so arm one would be standard of care with lemborexant. You would start at 5 milligrams with up titration to 10 milligrams. And then you also had arm two, which was standard of care with a placebo. It's important to know, and I didn't put it in the slide, but we did allow for recruitment of patients that had other psychiatric comorbidities, but we had to make sure that they were on stable psychotropic medications before enrollment. And we also excluded patients with untreated sleep apnea in our proposal. And the duration of treatment for each, for placebo and the orexin antagonist, was only about a month, with a 2-week washout period during the crossover portion. And so what are the things that we wanted to evaluate? So we looked at a lot of daytime questionnaires as well as sleep-related questionnaires. So we looked at the ISI for insomnia, the PSCI, the FOSQ-10 for and the Epworth Sleepiness Scale for sleep-related complaints. And then the IESR is one of the questionnaires that's been validated in association with PTSD. And in order to assess for objective measures, so we're looking at, this is the Knox A1. So this is a nice home diagnostic study. It can be completed in the comfort of the patient's home, but it also carries EEG, which you can see on this gentleman's head, which isn't common in home sleep testing, but allows for evaluation of things like arousal, true markers of sleep, so you're able to determine wake after sleep onset, and it allows you to infer stages of sleep a little bit better, things like deep sleep, and a different stage of non-REM and REM. So what was the barrier? So I told you that I was working on this for about a year or two, and then I got this email. So unfortunately, from the time of IRB approval of our study to actual implementation and recruitment, there was a change in regulation from New York State, from the Board of Pharmacy, the DEA, the Bureau of Narcotic Enforcement, and our original plan to have our controlled substance, so lemborexant is a stage 4 controlled substance, we would no longer be allowed to use our pharmacy. And so what we did, we tried our best. We received DEA approval. We had our security walkthrough. We had the Bureau of Narcotic Enforcement walkthrough. But due to the costs of the storage, we had to get a safe, we had to get a new security monitor that would have cost over $20,000. So unfortunately, we were unable to proceed with the proposed project. But hope is not lost. So the team was gracious enough to allow us to, formulate a new proposal. So right now, what we're doing, we're working with our occupational health team, and we're looking at patients with burn pit exposure. And so this is something that's not really looked at. There's only been one study. But our hypothesis is that patients who have, or people who have exposure to burn pits may have underlying effects on their pulmonary function, and underlying pulmonary architecture that can actually lead to these disturbances in, sleep-related metrics. And we're working with Dr. Tony Zima, who is actually looking at wearable technology, and we'll be able to look at things like hypoxic burden, which is some of the metrics that aren't always seen just on regular polysomnographic testing. So I'm out of time, but I really just wanted to thank my team. That's Dr. Greenberg, Dr. Moline, Dr. Diefenbach, and Dr. Butzko. There's also Ramona Ramdeo, who is our study coordinator, Caitlin, Zubair, Anna, and Saad, who have really been fantastic. And lastly, Miss Candelario, Miss Parks, who's hopefully now enjoying retirement, Dr. Chu. They have been extremely patient and supportive during this process, so I cannot thank you enough. So I'm a little over time, but just want to say thank you for everybody's time.